Hi there, it's Archie. I'm back for the ADHD Care podcast. I hope you're doing well today. Today, I'm pleased to say I'm joined by Professor Susie Young. I've known Susie for a number of years now, since I first came into this field of neurodiversity over 20 years ago. So, Professor Susie Young has extensive clinical experience in the assessment and treatment of young people and adults with ADHD, and also in the assessment and treatment of offenders with mental illness and mental health disorders. So Professor Young previously was employed as a clinical neuropsychologist at the Maudsley Foundation Trust Hospital, where she set up and developed the neuropsychology service at the first adult ADHD service uh, in the United Kingdom. So Professor Young has, for many years, has worked in forensic services where she's provided forensic clinical psychology services to offenders in prisons and mental health settings. She's also worked in the community in low, medium, and high secure settings. She's also has extensive experience in the assessment, treatment, and management of offenders with mental illnesses and mental health disorders, particularly specializing in forensic neuropsychology and neurodevelopmental disorders. She's published books as well. She's got her own website. I know she's involved as part of the community that was involved in creating the NICE National Institute for Clinical Excellence guidelines of ADHD children and adults as well. That was back in 2007 and also in 2017. And she also offers training. So there's a lot that I'm excited to be discussing with Professor Young. So let's bring her on.
Okay.
Hello.
Hi. Sorry, I had to push a button. How you
That's all
doing?
right. I'm good, thanks. Good to see you.
Good, and good to see you as well.
It's been a while. How are you doing?
All right. All right.
Yeah,
Yeah, busy. Hectic as always. Yeah.
I can imagine. I can just imagine that. Yeah. I've been looking forward to this because we haven't really caught up for a long time. I think the last time we had a chat was one of the conferences that you were presenting at, and I thought we spoke briefly, didn't we? I think I can't
I
remember.
know. There's
Yeah.
never enough time with anything. I don't even have time to go to one of the conferences unless I'm speaking at it these days. So
Oh no. Good. Perfect. So, thanks for spending your time to come onto our podcast and to discuss about your career and just to get your insights on a number of things that I wanted us to cover today. So, just to kickstart the conversation, really, do you mind just sort of sharing a bit about your journey in the field of ADHD and forensic psychology?
well, it started a long time ago, Archie. In 1994. So
Wow.
actually, this is my 30-year anniversary of being, it was
Wow.
about this time 30 years ago,
Wow.
when I set up the adult ADHD service at the Maudsley Hospital. And actually, lots of people thought that Philip set it up as well as the psychiatrist, but he didn't. He came along 2 years later. It was a doctor called Brian Toon, who was a psychiatrist then at the time. And I remember well that when he was leaving, because he retired, we were thinking, well, what's going to happen to this service? Because it was just overrun with referrals.
Yeah.
And I remember Eric Taylor smiling at me and saying, "Don't worry, there's someone in the background who's coming forward." And of course, that was Philip Asherson, and
Right.
that set off a long time with me working with Philip at the Institute of Psychiatry. So yeah, so it was a long time ago, and we used to get one line referrals from GPs saying, "This man says he has ADHD, please advise." that
Wow. Wow.
and we'd also get referrals from all over Europe, because there were no other services like that anywhere at the time. um
Wow.
so when you think now what it's like now, the explosion of services, like it's life is so different today. But also, it was through that early work that actually I first started to get interested in offenders with ADHD, because what would happen is they'd be booked in for follow-ups for treatment for their medications, and with Dr. Toon, and they wouldn't turn up, and then a few months later they would, and they'd call back in, and I'd say, well, what, you've missed, you missed your appointment, we never heard from you again, and you've turned up 6 months later. And they'd been in prison. And then
Wow.
I started to notice this pattern. And so we started to routinely ask questions about antisocial behavior. And that's really what set my path off as well, not only in adult ADHD, but also in offenders with ADHD.
Makes sense. And you know, I didn't even know that link that you just said there, which completely makes sense. So what were some of the major challenges that you came across, particularly when you were kind of being involved in establishing that first adult ADHD service in the UK?
Well, the huge one was there were no measures. There were no
Right.
measures and no treatments, but we didn't know about what you know, we didn't, we were thinking about, we had to identify what could we use to assess ADHD. Are there any specific rating scales? But there wasn't anything, because everything was normed on children.
Right.
So, you know, we had to start developing things ourselves. And certainly it was from those early days when I first wrote, well, everyone used to call it the Yellow Book, but when it was redone, the CBT for ADHD adults, that was a Yellow Book initially. And then when we revised it in 2012, Jessica Bramham and I, it became an Orange Book.
Yeah, I remember
Yeah,
that.
but someone's written on Amazon that no wonder everyone refers to it as the Orange Bible. I didn't know that, but I thought, yeah, I would have paid her to write that, you know. But I was very flattered, and it's very reinforcing actually, because it's a lot of work doing this stuff, and it's really nice to get that feedback, really, to have people let you know that they value your work and what you've done so much. So
Yeah.
I think we were really hampered at first, and we had to develop our own protocols. The measures that were available were all done on male boys. They were all done on children. There were no norms for adults, and there was a lot of stigma. Huge stigma. As I said, even the GPs, this man thinks he has ADHD, please advise. And no one was even thinking about, even us in those days, about how many people with ADHD were being misdiagnosed and were presenting in other services, addiction services, sexual health services, you know, or anxiety services. That no one was really thinking they are there somewhere, but they're in the wrong place, maybe. Our thinking, we didn't have the volume of scientific knowledge and research that we have got now today.
Yeah.
So
I suppose because you didn't have the NICE guidelines for ADHD adults at that time, did you? So
no, they
that makes
came along in 2008. It was, that was, and I sat on the guideline development group there. I was one of the people who did that with all my colleagues. So it was just it was really, the service was set up because what was happening was people in child services, because I was initially doing my PhD, and I was doing a PhD in females, another early marker in my career, in females, but in girls, and I was doing a longitudinal follow-up of girls. So Eric Taylor was my supervisor there. And what the child services were experiencing was that they were growing up, and they were leaving school or going to work, and there was nowhere for them to go, and they still were presenting with ADHD symptoms. So the child services were struggling with the capacity to continue to support and manage young people with ADHD within their services. And it was not unusual for some people to hold on to them till they were 23 years old, or through university or through college, simply because they had a relationship with them and there was nowhere else for that young person to go. And that was one of the reasons that the adult clinic at the Maudsley was initially set up.
Yeah, yeah. And again, to bridge that transition, which is very crucial, we know, particularly with, with ADHD moving from adult to childhood. what would you say has changed? What have you noticed, particularly public perception, professional perception of ADHD over the years throughout your career? What have you noticed that's evolved?
Everything. I mean, like thankfully, we're in such a different position today, completely different to where we were before. And that's because of the research and the knowledge that's come through. And we are at the moment in an unusually heightened state, I think, of awareness. I mean, it seems, I don't know about you, but I feel that I can barely pick up a newspaper these days without something about ADHD being in it, being in it. And they're not all positive stories, it has to be said, but most of them are. So I think some of the big changes, though, has been that it's no longer thought to be a childhood disorder for boisterous boys, that it's seen, the neurobiological underpinnings are widely accepted, and that it's recognized that girls have ADHD as well as boys, but they present slightly differently, which presents a challenge, a greater challenge to many people who are perhaps not so aware of the differences. That's one of the reasons why we wrote the consensus statement about assessing and treating girls and women with ADHD. And if any of your listeners are interested in that, that's I always forget what publication it's in. I think it's BMC Medicine, and it's free to download. It's in open access. If they search my name and females and ADHD expert consensus, they'll find that there. So we wrote that. So of course, now we know adults have ADHD. We know that people with ADHD can also have comorbid autism spectrum disorder. So that in the old days, we were assessing ASD as a differential diagnosis. We were kind of screening out. So because the diagnostic criteria said that you couldn't have both, it was either or. And then, of course, all the research started coming in supporting that there's a lot of similar underpinnings, and that these two conditions can present together alongside each other. And so now then that was changed in the diagnostic categories of DSM and ICD. So that's more accepted now, and that's been an eye-opener for many people, because we kind of have a better understanding really of knowing that people with ADHD can also have autistic traits with hypersensitivity to noise, for example, or sensory issues. They also kind of may stim to self-soothe. And also we see ADHD traits in people with autism. So it's understanding the difficulties and the presentations of the individual. That's much broader now. And for me as a psychologist, I find that really helpful, because it's not all about a label. I know we have to have labels so that we can give people medication, and I accept that. I'm one of the people who accept that there has to be labels, but the labels don't really capture the individual needs and the unique needs of that person, and that's important to see. I think public opinion has been swayed a lot by celebrities coming out. But I also think that that's been a double-edged sword. I think it's good because it's given young people more confidence to talk about ADHD, to say that, and to disclose that they have ADHD, and to have their voice heard and be less concerned about the stigma. But I think that the celebrities, it's made it a little bit popularist. And, and I see things on TikTok, which really, there's some things on there that it's just rubbish, to be honest. I'd like to find a better word for it, but it really, and it's misleading rubbish about ADHD. And, and so they there's a bit of a swing the other way with people thinking it's being overdiagnosed now, and that people are misdiagnosing people with ADHD when they have other difficulties. And I think that may happen a little bit, but for the most, I think for people with genuine ADHD, my feeling is that it's still underdiagnosed.
Yeah.
We now just need to develop all the services better, and the services within the services, to make sure that people's needs are being met fully.
Yeah. And I suppose for the NHS as well, at the time when you set up the adult ADHD service back, over those years, for them to actually fund the service, they could actually see that there was a need for it. Clearly, which is
yeah, there is, but they recognize, for example, they recognize there's a need for psychological treatment now, but they're not funding that, though. I mean, so they don't fund everything. So they might fund a service, but it's not necessarily a comprehensive service that's meeting everybody's needs. That's what I meant.
And I'm glad you brought up the NICE guidelines. Again, going back to the NHS, because the things that they recommend, you mentioned about psychological interventions and things, the NHS isn't necessarily funding those things. They're not readily available. Most people are offered medication or nothing, coaching, all of these things. You can't access them via the NHS. So, yeah. So, what's your thoughts? Obviously, because you were part of creating these recommendations when you set up the NICE guidelines. What's your views on that?
On what? Sorry, Archie. What's
So
my view?
just in terms of, like, obviously the recommendations that the NICE guidelines do say about children and adults as well, interventions, non-pharmacological interventions, that is, anyway. I know you're an advocate for, CBT, therapy, psychological interventions and things like that, but someone who doesn't want to go down the medication route, for example, who wants to access these services, they're not available via the NHS.
No, well, they are in some, they are, but not very much, and it's limited.
Yeah.
It's certainly not what people need. And NICE, NICE is a guideline. NICE can set kind of the guidelines and the standards. But one of the things that I learned when I worked on the NICE guidelines with them, because I was also asked to be part of the implementation team to discuss about how these, and give advice about how these guidelines can be implemented within the trust. And what I learned is actually that they're not rules, they're guidelines, and people just don't have to implement them. So really, guidelines can say what they like, but it doesn't have to be implemented, which is a little bit of a shame. And arguably maybe they should, or maybe that just would be too prescriptive. I don't know. That's for the NHS to answer, really. But yes, people can't get it, and what that's doing is it's driving people with ADHD to seek these treatments and these non-pharmacological interventions into either the private sector or the charity sector. And what that means, there's been an explosion of practice of people providing these treatments, but it's setting up a two-tier system within the NHS and private practice. And should we say, not everybody has the integrity that I think is needed for private practice. I worked in the NHS for many years, but when someone can become a coach, for example, and go on a coach training, and they have very little background knowledge in this, they have no clinical understanding of ADHD and the presentation of ADHD, perhaps other than lived experience, and yet it's not a regulated profession, and yet they set themselves up and become a coach. If you ask coaches what is the difference between coaching and CBT, most of them can't even tell you. So they can't define it very well either. So that does concern me, that this, and I know some very good coaches who are really good people, but I've also seen I've seen clients myself who've been to see coaches or had therapists who've caused a lot of difficulties. And I think, not intentionally, no one does that intentionally, but I think that what happens, someone can accidentally, with a question or an exploration, open the can of worms, and then they don't have the skills to close the can again. And that's the problem. One, it's out there and it's there, and someone can become very distressed and thinking about past traumas, and a coach, that's not their role. And the most important thing is that they know when to refer on. And I think that service users who are listening to this, I very much hope that they will hear what I'm saying and check out the qualifications of the person that they go to see, because you should be able to find this person's professional body. They should be a member of a real one, not some that you've got to look and see what the professional body is, not something that's been set up just to and has about 100 members or something, so that's the big thing, is to make sure that the person that they're seeing is qualified to do the work that they need that person to do. So I'm a clinical and forensic psychologist, as you know, so we're regulated by the Healthcare Professions Council. And it means that our titles are protected. So no one else should be able to call themselves a clinical psychologist or forensic psychologist. That, unfortunately, isn't the case with coaching.
Going back
Sorry, that was my soapbox then.
Of course. I was going to take it on a completely different tangent, because obviously the same could apply by what we're seeing with the explosion of private services. Now you're having people that have had limited experience of having, assessing, treating, managing ADHD, being trained up to do assessments. And, I don't want to kind of focus on specific professions here, but the same could be said, because the thing is, it's not being regulated privately. There isn't a body that would, regulate someone saying, okay, you want to go into private services, okay, you need to, a vetting sort of website or body that would vet everyone before they actually set up a private service. Moving on from that, I want to talk about the link between ADHD and criminal behavior, and get your views in terms of why it's important I think you mentioned about you were screening for that as well, but what's the relationship between ADHD and criminal behavior?
I think it's impulsivity, and perhaps and data shows that a history of conduct disorder is also important, but we've also got data saying that people with ADHD will also offend, even when they don't have a history of conduct disorder or conduct problems as well. So I think it's about impulsivity and about emotional dysregulation. So people with ADHD, they're not going to be the individuals who make a big planned, complicated kind of white collar crime, or a jewel heist, or it's not going to be an organizational crime. It's not going to be a great planned out thing like that, working with people. It's going to be opportunistic or reactive. So they're the people who see perhaps someone's left keys in the car and whizzed up to the post box to post some letters, and they'll and they're the ones that jump in the car, have the opportunity, and go off. They don't notice the CCTV that's watching them, or somebody is noting what they're doing and making a note. So it's opportunistic. Or they're the people who will be getting into fights in the pub. It's reactive and get into trouble that way. That they don't think of the consequences. They don't stand back. They just think, there's no filter, bang, and then they get into trouble. So I think that's the route. That is a route for many other people without ADHD as well. But I think almost exclusively that's the difficulty for people with ADHD in the data that I've done, what I've looked at. So I think that's the routine. But of course, once they're in that cycle and they're in, it's very hard to break it. And what they, when we were doing our big study in Aberdeen, we were there for over 2 years, and we assessed 490 people, I think it was, in the end, in Aberdeen prison. And there was a lot of data that we were getting. And sometimes it involved several meetings with the research assistants, and sometimes they would be gone. They'd be, they'd be released, or because they'd be on remand, or they'd be there. They'd finish their sentence and they'd be leaving a bit earlier, and they'd go. And we'd say, oh, I remember one of the research assistants said to me, she was speaking to a prison officer and said, oh, that's a shame because I was only halfway through. And the prison officer said, don't worry, he'll be back. And that's exactly what happened. They were back. They're revolving door offenders that are going in and out, in and out. And it's very hard to break that cycle and to break into it, because they struggle in the young people who are in youth offending institutions. Sometimes they're locked up for 21 hours a day. And then they don't get the opportunity to get the exercise they need, and they struggle in these confined spaces. Then they act out, they get into difficulties. They're not seen as model prisoners because they're temperamental, they're getting distressed, and that means then that they're not going to get out on perhaps early release. So it all, they have more adjudications, so they get caught in this negative cycle that is really very hard to break.
I think back to my days when I worked in CAMS, whereby we had a youth offending service, but I don't think they would routinely screen those young people for ADHD, because those two services were separate. The youth offending service wasn't actually part of CAMS, although they were meant to be, but they were literally away from the building as well. Yeah, sometimes we would have a few cases that were, mutual cases, but I don't think they were doing the routine screening, as you say, because obviously that age is crucial to pick up ADHD in some of these young offenders. I'm not sure what the setup is now. Go on.
Yeah, no, you're absolutely right. And I always say, because these young people are moving from classroom to courtroom, right? So that, and it's essential to identify them. I think in some prisons things have got better. What they've always said to me is that we need brief screens. We can't add another great long screen during at reception when they're being processed, when they're going through the system. So actually, one of the outputs of the study I referred to in Aberdeen what was that we developed a brief screen that had good sensitivity and specificity. I can never say that word, specificity. What it means is it reduces the false negatives and maximizes the false positives. So it was a very good screen to do, and that it's called the B-BARS, B-BARS, and it's a briefer version of the Barkley scales. We started with those, and with our statistical analysis, we did regressions to see what items predicted a diagnosis of ADHD in that group. And some prisons have taken that on board. The trouble is, because I make my materials free to download from my resources section of my website. But what that means is I often don't know who's using what where, and I have heard that these are being used in some prisons. So I think it's different. But you're right, it's so important that they are identified, actually for two reasons. One is because we need to get these young people out of prisons and into constructive employment. So if we know that they have learning difficulties because they've got ADHD, then the education will know what the education in the prisons will know what they're dealing with. The occupational programs will know what they're dealing with, and hopefully it will be a better environment for them to progress through if everyone understands their underlying neurodevelopmental condition. But secondly, and really importantly actually, is that the risk of suicide with young people and adults is in the first 2 to 3 weeks of them going into prison. And so it's so important to recognize and know who's got ADHD, and so who might impulsively act on the thoughts of feeling extremely low and depressed, and thoughts perhaps that they've let people down, thoughts that no one cares about them, that this is the end of their world, the world for them, and that they have no option but, and they have suicidal ideation. They might act on that ideation. So that's another really good reason why we need to identify these young people early on.
Yeah. In terms of rehabilitation, as you say, the revolving door, what's been done to help and support some of the young people, even grown-ups, adults who have ADHD, who are offending and going into prisons and reoffending? Does the rehabilitation consider ADHD, be it strategies, it could be medication, it could be psychological support? What would you be advising?
Well, I think that certainly they need to get medication and to be treated with medication if that's appropriate for the young person. And I think that those who have ADHD, that are known to have ADHD, I think that my understanding is more seamless now. There will be someone who will be listening saying, no, it's not. They'll know a different story. We all know different stories. But I think it's sort of getting there. I think there's a problem perhaps with getting the assessments done in the prisons. It's just a much longer process of getting these assessments done and then getting them onto the medication. The rehab, though, in prisons, the offending behaviour programs are all really quite long group programs. So if you can't settle, if you can't focus, if you're in a group, there's loads of distractions, then that's going to be very difficult for someone with ADHD to attend to and concentrate on, and and be in. And I think so often these programs are a box ticking exercise, like, yeah, they've done this and they've done that. It's something to be said, well, they've done it. And what we really need is people to be able to develop, to translate the skills that they learn in these groups into everyday life, into their daily activities. There needs to be a bridge. And that's why with a lot of the rehabilitation programs that I've written, and I'm thinking in particular of R&R2 ADHD or R&R2 MHP. The first one is for youths and adults with mental health problems, and the ADHD one is for youths and adults with ADHD. You might have heard of them, Archie. So yeah. But with those programs, what I did, they are group programs, okay, but they're kind of engaging. They're kind of written for people for the ADHD one, for people who may struggle in a group. So you're switching activities all the time. You're perhaps writing things down. You're talking. There's moving from the group to individual work, and but there's what's called a PAL, a participant aid for learning, who meets with the individual outside of the group, and they have a one-to-one session with them outside of the group. And the aim of that meeting is to take what's been learned in the group and take these skills and to help them with homework and things that they need to do outside of the group, with the aim of transferring the skills from the group into daily life. And in fact, there was a prison, one of the what do you call them, the prison visits, the people who, the inspection. There was a prison inspection at Feltham YOI several years ago, and they were running R&R there, and it was commented in the report that they think that this model of having these individual sessions, having the PAL do this, was so valuable, because it really helped young people. It transfers a group skills into a personal program. It becomes more personal to them. So yeah. I think that's what's needed. It is there. I mean, R&R2 ADHD is being used all over the world. And if I have a few minutes, I'd like to tell you the outcome of a Danish study. They ran it in several municipalities in Denmark, and comparing post-treatment, comparing people with ADHD compared to people who are receiving treatment as usual. There was, improvement in ADHD symptoms, improvement in social functioning, emotional control, and perceived quality of life, and personal locus of control, having more personal control over your feeling, you have more personal control over your actions and behaviors. And there was a reduction of anxiety and depression and anger post-treatment, and that these findings were sustained at 3-month follow-up. And in fact, some even further improved, the treatment effects increased. And we found that consistently with this program. But what they did in Denmark, which is so exciting, is because they have big registries there for people from birth. Everyone is, the details of people are all on a registry. So they did 6-month and 12-month follow-ups versus matched controls taken from these registries, from registry data. And what they found is, first of all, they found that those individuals had been in the group there was an increase in engagement in constructive activities. They were more likely to get educational, enter education and get educational qualifications and jobs and work. That they were much more likely to do that. So that's exactly what we want people in prisons to do, isn't it? It's exactly what we want. So that was a real good positive finding. But secondly, they also found that there was a reduction that was made in social security benefits. So in other words, they came off benefits and into education and employment. So that's a real, I can't think of a better argument for people who to invest in programs. I mean, obviously this is the one that I wrote, so I'm happy about it. But there will be others to invest in programs like this. Yeah. That will get these kind of gains, and it does show the way as to what young people need.
100%. Let's talk about transitions from childhood to adulthood. What advice, tips would you have? Because it's a tricky. I think we talked about it from a in terms of services being set up, and now we've got the adult ADHD services. But what are some of the key take-home messages for our listeners that they need to be mindful of? Because a lot of young people struggle, and I see it in my practice as well, where parents might think the young person is 18, they're independent, they can just start doing things on their own. Some of them move to university, and you find that some of them drop out of university because now they're having to be more independent. The demands, the expectation, it's such a significant period to go through. I just wanted to get your take on that, really.
Yeah. We talk about transition as often being a move between services, from child to adult services. And actually people lose sight of the fact that this is a personal transition for the young person. It's a time when suddenly they'll be leaving school, maybe going to college, going to work, doing something different, leaving home, moving away from home for a period. And they lose the scaffolding of the home environment and also the scaffolding of a school environment, and suddenly life is very different. They have to take greater responsibility for their behaviors. They're expected to do things themselves. So take young people going to college and leaving home. They're away from their friends. They've got to make new friends. They've got to get used to a new campus. They've got to get used to a new curriculum. And actually, often they've lost the routine and structure of school, of a strict timetable, right? Suddenly they're doing something 2 days a week, and then it changes every term, and they're in different places, and a campus might be very big. They have to register for a GP themselves. And I can't tell you how many young people I've known, and that's the key where it falls down immediately. So if any parents are listening, please, if your child has got ADHD, please help them to make sure they register with a GP wherever they're moving to in the future, because then they've lost all of that medical scaffolding that's around them as well. And then, symptoms become worse and they're not having their meds. And so many young people, and the data supports this, so many young people at this age, between the age of probably at 17 and 25, that they stop taking their medication. And, you know, I'm a psychologist, I'm not pushing medication on people, but if people benefit from medication and it helps them, it's really important that they stay on their medication. I mean, and many adults, they do manage their medication as and when they need it. And that can be done, but they can't access any of it. Because they're not being prescribed it because they're not with a GP, for example, or they had to take that responsibility themselves. So one of the big things is, you know, remember that their kids, they've just left home, they've just left school, they're leaving their friends maybe, you know, and life is changing very much. Even for those who stay at home but go out to work or at college or wherever nearby, it's still, everything's different. The social demands on them are huge to fit in, to be one of the crowd. Do I disclose I've got ADHD? Don't I disclose I've got ADHD? What do I need? Oh, there's so much to do. Have I got everything? I haven't got someone here to pack my bags and, you know, and I think, and that's where all this masking and camouflage comes in, and compensatory strategies, some of which are excellent. Some people find really good strategies to help their way through, but some they find dysfunctional strategies. They start drinking too much. They start smoking cannabis. They start self-motivate, self-treating with cannabis and smoking a lot of it. You know, like things can slide very quickly. So there's a difference if they're left home and if they're still at home. For those who've left home, if a parent's listening, I would say, you know, call them regularly. They might not talk to you much about stuff, but call. Right? Even if they sort of say, yeah, I'm fine, I'm all right, just okay to have a little chat, tell them how the cat's doing or whatever, and then end the call. But keep the link going. And as for the young person, yeah, life can be difficult. You've got more responsibility. It's important that you develop a supportive network around you. So if you're still in further education, to disclose to the disability staff that you have ADHD. There's no shame in having ADHD. will.i.am has ADHD. You're thinking out of the box. You're innovative. You're creative. You have something to offer. So don't feel shameful about that. So tell people, and you know, but also be careful you don't over disclose to people about all your life in an effort to fit in. So keep to your principles, and take your time with making friends, and it will come. For people who are working, perhaps are still living at home, who want to be independent, you know, and I know it might seem parents can be a pain in the neck because we ask questions all the time, and you know, and they're nosy. They're just interested actually, but the kids think we're nosy, you know, like so yeah, just spend a bit of time to in your head, have a bit of dedicated mum and dad time to talk to them. Right, just to talk generally, so that keeps them happy, and then carry on with your life. But at work as well, disclose you've got ADHD, because unless you do, you can't get the reasonable adjustments that you might need.
I was just thinking about how services are set up in terms of having children's services, adult services, and it's very clear cut when someone turns 18, particularly in the NHS, they are discharged, they have to be moved on. And usually when adult services pick them up, they are treated as an adult. Before, I don't remember the period where we used to have transition services where they'll bridge the gap, 16 to 25. Do you not think having something like that would be quite good, particularly for some of these young people that we're discussing who are moving into becoming adults?
Yeah, what I think, see, I only work privately now, but when I have young people of that age, I give them the option to have parents in with them. I give them the option to do that, and often they will say yes. you know.
Yeah.
But I always talk to the young person on their own as well. I'd send the parents out. No, always talk to the young person on their own. But because the other thing is, if you think a parent perhaps has taken the heavy load for organizing, managing, arranging, doing things, and then and suddenly they're not needed anymore. They're out of it. And that's very difficult for a parent or the caregivers to accept and to take, because they feel powerless. They're not in the loop to help. The other important thing is, if your child does get very distressed and you notice the signs that they're getting very, very distressed, keep an eye out for cutting, because they'll cut where you can't see it. You know this, Archie. They'll do it sort of on the top of their thighs and things like that. And I think, so many things like this, the risk of self-harm if people are getting very distressed. I think it's good to signpost these things for parents to know about it before they're considered not needed anymore, because they are very, very much needed in the support of that child. So personally, I think services, I don't see why they can't. They should be able to have that young person with them, especially when they're first getting to know them, but to offer to the young person to say, you can bring an adult with you, a parent, if you would like, but I will want to spend some time every week speaking with you on your own. And I think that's the way forward. And I don't think there's any rules or anything that says that can't happen.
And just reflecting on your sort of distinct career, what would you consider as your greatest accomplishment in the field of ADHD? Where do we start? I'm sure there's many.
Tolerance. I think actually I think my greatest achievement is with the legal work I've done. I've done Court of Appeal cases that have actually set legal precedent for people with ADHD, one in their fitness to plead and stand trial, and the other in mitigation of understanding how a person's behavior might be influenced or impaired by their symptoms of ADHD. So those cases have changed the law, really, because they've set legal precedent that can be referred to later. So I suppose those are my proudest moments, because if I think, if you do something that changes the law, then that will, then I guess that's it. But I only thought about this recently, because I don't know if you see, I've been put up for a Lifetime Achievement Award at the International Diversity Award. And I was asked a question similar to that. And I don't really think of that as being the achievement, but I suppose that has to be. I had to think about it, because I always think I have achieved a lot, and I've set out to do things that I want. But the trouble with me, Archie, is that there's so much more I still want to do. I'm really focusing on what's next rather than what I've achieved and done. I don't spend time wallowing and tapping myself on the back and thinking about that. But if any of your listeners want to vote for me, please do.
And if they do, where do they need to go for that?
Oh, there's a link. I can give it to you. The National Diversity Awards. I think it's Susan Young. Yeah.
Right. You touched on women and ADHD a while ago. I just wanted to briefly come back to that, because this is something that some people ask me, like, are there specific rating scales that we should have that screens for ADHD in women? Should women the treatment for ADHD, should it be different to males? Just how ADHD presents in females, we know there's a bit of a difference there. What's your views on that?
Well, they're obviously less hyperactive. I mean, people think that with females, the stereotypical understanding is that females are all inattentive type and males are combined type, and females have all internalizing problems and males have only externalizing problems. In fact, that's not correct. They're both as likely to have inattentive type. They're both as likely to have combined type. They're both as likely to have internalizing and externalizing difficulties. It's how they're expressed that's different. And so boys, I mentioned before, the boisterous boys, they're the ones who are very hyperactive. They'll be the kids who are running around under your desk, sticking their fingers in plug sockets and things. But the girls are it's all about social relationships. It's much more social relational. And I think that their impulsive difficulties are expressed in over disclosing to form perhaps social networks that are perhaps dysfunctional social networks. Like, it's sort of any friend is better than having no friends. They're getting that they're vulnerable to being victims. Their psychosexual behaviors, they're risk taking in terms of their sexuality, and putting themselves at risk at times. So and in fact, I think that one of the places we should be screening for ADHD is sexual health clinics because of the high rates of sexually transmitted infections, and with the females with early pregnancies when they're young, and they're single parents from a young age. And imagine with an ADHD child. And so that's hampering their occupational, they're disadvantaged educationally and occupationally, from that perspective, because they're single parents, but like with one or two children or even more, trying to raise them. So I think the problems are different. So I think that with treatment wise, the advice for medication is no different between males and females, except with females, because of the relationship with hormones, the relationship between symptoms and hormones that's come to light in the past couple of years. And we do need a lot more information about, we need more research on that. But essentially, it's a seesaw. As estrogen goes down, ADHD symptoms get worse, and vice versa. So it kind of seesaws up and down. So that means that females probably need to be monitored, and they can do this themselves with a diary, monitoring your symptoms during menstruation, because medications may be less effective during those periods. So they may need to talk to their psychiatrist about having a top-up, a short-acting top-up during those periods. So that would be for, I'm a psychologist, but that would be for a psychiatrist, a decision to have with the doctors or a prescribing nurse about that. But they and also many women are coming forward in their 50s now because of the menopause. So again, as the estrogen ebbs away, they've managed symptoms perhaps all their life, just about keeping their head above water or finding strategies, and suddenly they can't, they're presenting saying, I don't know, I've always been like this, I've always managed it, but now I can't. What's going on? And so I think it's this relationship, this hormonal relationship. So that affects really treatment with pharmacological treatment for females. Non-psychological treatment, I think the focus will be different. So obviously with males, it's going to be much more behavioural. It's going to be more about overt kind of aggression, or conduct problems. With females, it's going to be much more about social relationships and generating more better interpersonal relationships, better social networks, finding people that they can trust. Because when you talk to the girls, my PhD was done on teenage girls, and there was so much their deliberate self-harming behavior, suicidal attempts. There was so much distress there, and feeling that they didn't fit in, and having no one to talk to, and just feeling they felt so misunderstood. So I think that the type of treatments and approach you would have might differ between the two.
Yeah.
I need to write more about that. Yeah.
Is there anything that you're currently working on research-wise, or anything that we need to look out for, just for our listeners to, for us to get excited for as well?
I've got 3 book proposals in.
Okay.
So, yeah, I haven't written any books for a while, and I want to do. I've got 3 book proposals in about assessment of ADHD in children, assessment of ADHD in adults, and about like adapting to the world of work from and about having to do that and getting a good and managing a good life, a good work life balance. Those are the kind of things that I'm focusing on at the moment. And the other thing is I'm hoping to, the ADHD child evaluation and the ACE Plus for adults, the assessment tools that I have. They're free to download from my resources section in my website, but I'm looking into digitizing them because everyone now, we're in the digital age, and I'm, the least technical person you'll ever meet. But so I'm sort of being kind of having to grasp it and to improve my learning curve about that, and I'm trying to do that at the moment.
But you got the B gaze. Do you remember B? Is it B gaze?
No, that finished.
Right.
That didn't work out, unfortunately. So I'm and we're in the world of AI and everything now. So I have something kind of in mind. I just need to. I've got meetings and we'll see whether I can afford it.
Of course.
But yeah.
Are you still running the CBT for ADHD training for professionals? You remember the training I came to? Yeah.
Yeah, I do. I do that. Yeah, I do the training still. But most of the other thing I'm trying to do is, because what I find is people want me, they don't want other people. So I'm trying to put my training all online on demand. I've got this American platform called Teachable. And it's on my Teachable platform. If people go onto my website, they'll find the links, but I'm putting training on there, so it's on demand online, so they can just watch it at their convenience. And the other thing I have on there is a set of 10 top tips for parents and caregivers for for managing children with ADHD and something else. So it's managing inattention in people with ADHD, and managing impulsivity in people with ADHD, sort of but also anxiety, low mood, frustration and anger, problem solving and ADHD. They're all tips that people can access if people prefer to have something visual.
And that's on YouTube as well. That's on your YouTube.
It's not on YouTube now. It's on. No, okay. I have other things on YouTube. I have someone who's been taking me to task with social media. I've been doing these YouTube shorts. Only it's so hard to say something meaningful in less than a minute. I fail miserably, so thank you for giving me an hour.
That's absolutely right. Thanks for spending your time, and great to catch up with you again. And go well. Enjoy the rest of your day.
Bye.
Bye then. Bye.